Okay, so hypertension and chronic kidney disease, quite high prevalent topic. It reflects a significant amount of morbidity that the population carries. So we'll try to address it. Again, one of the things that Dr. Dhananjaya brought up is very important. Any questions, please type it in. I'll try to break up the presentation and ask for any kind of input or questions that people may have. So what is hypertension and how important is it, and why are we addressing it? And I hinted towards that right at the start. It affects up to 30% of the United States population. And as we grow older, by the time we hit our 70s, up to 65% of the population can be affected by a high blood pressure. The cost is not to show how much money is being spent, but to show how important of a disease it is. It can cost upwards of $70+ billion. This data is already 4 or 5 years old. So that number is only going up and shows the investment that's being made in the medical field in order to address hypertension. And then we'll address what is the difference? How do you distinguish somebody from just having high blood pressure, which is unfortunately a majority of the time genetically mediated, versus secondary hypertension, where we do more of a workup and try to find something that's more disease-modifying therapy, more directed towards a specific etiology of a high blood pressure in patients. And secondary hypertension does tend to show up more commonly in the younger population. So this isn't new. We all know about high blood pressure, and clearly the interest in the community shows how aware we are of how significant of a problem high blood pressure can be. But despite that proof that treating hypertension dramatically reduces morbidity and mortality, and I'm sorry, I skipped past a slide, maybe it's here. One of the first slides I was meant to put up was definitions. As physicians, we tend to use abbreviations and some terminologies that we really need to explain better. So some of the terminology that show up: hypertension, HTN is for hypertension, BP is blood pressure. A blood pressure reading itself is made up 2 variables, the top number and the bottom number. The top number is the systolic blood pressure, which carries a greater morbidity and importance in high blood pressure. A lot of the data seems to suggest treating that systolic number is more crucial than diastolic, but diastolic number cannot be ignored. It also carries significant issues for the patient. So the top number is systolic, bottom number is diastolic, but both of them together make your blood pressure. Morbidity is saying if you leave somebody untreated for blood pressure, what is their risk for having a stroke or a heart attack or chronic kidney disease, such as in our presentation? That means that there's increased morbidity, meaning there's increased risk for other problems that can occur, and mortality speaks in its own. What's the risk? Does it increase the risk of death if untreated for patients? Ambulatory blood pressure, you'll see me mention that a few times along the way. That means doing your blood pressure at home, taking your blood pressure at home, and we'll go over a skill sim lab, so to say, of how to properly, which blood pressure cuff is proper to use. And I'll have a picture kind of showing what the proper way of taking a home blood pressure is. And then the last 3 are kind of going over some blood pressure treatments, and the most common being a thiazide, which is a water pill. It's a first-line diuretic, as we call it, for treatment of high blood pressure in the majority of the patients. And then the next 2, an ACE inhibitor, is a class of blood pressure medications, very vital in the treatment, and at times can be first-line agent, especially in diabetic patients. When I mean first-line agent is after doing lifestyle modifications. When you need medical therapy, we tend to jump towards either a thiazide diuretic or a ACE inhibitor, as you'll see near the end of the presentation. And lastly, another class is the ARBs, or the angiotensin receptor blockers, which are similar to ACE inhibitors. Just understand you use either or, and we do not tend to combine those 2 drugs in classes of drugs in one patient. So again, overview. Despite this proof that hypertension is bad and can lead to more badness in terms of chronic kidney disease, heart disease, etc., it's still improperly treated in a lot of patients, or undertreated in the majority of the patient. And that's why it remains one of the world's greatest public health problems. So what are normal blood pressure? It's debatable, to say the least, but in general, less than 140/90 would be a reasonable normal goal for blood pressure. As I've already mentioned, by the time we reach the age of 70, up to 65% of the population can have high blood pressure. So the prevalence increases with age. And race is also an important. Certain races have a higher tendency to develop high blood pressure earlier on. Male versus female is also an important variable. So the key towards hypertension is, of course, prevention. We want to prevent any of the end organ damage, as it's termed in the medical terminology. And in this case, we're talking about how to first treat hypertension and how do we see it improve chronic kidney disease outcomes in patients. And just remember, a 3 months delay in treatment of high blood pressure, just a 3 months delay can lead to a 2 times increase in having heart disease and increased risks of death. Very significant and should not be taken lightly in how we go about doing it. So blood pressure accuracy. We need an appropriately sized cuff. And when it says bladder length, so the whole thing is the whole cuff is considered the bladder. This is an upper arm cuff. I prefer upper arm cuff. You can certainly use wrist cuffs too, but there's better data to support upper arm blood pressure monitoring at home. So the length is considered this portion here of the diaphragm, and it really should be 80% of the circumference of the arm, and the ideal width. This is the width. This is the length. Sorry about that. This should be 40%, and this should be 80% of the circumference of the arm when you're doing blood pressure at home. That second part, it's talking about more of the manual, but here, these are more of the automatic. Just make sure this portion here sits right over the mid portion of your elbow, right here when you're doing a blood pressure. It picks up your brachial artery pulsation as it measures the blood pressure. This picture here, it's taken straight from the CDC guidelines and what the appropriate form should be when you're taking the blood pressure. Try to avoid having eaten or drink anything within 30 minutes of the window of taking your blood pressure. Make sure you have an empty bladder, things that probably are common sense when you're approaching it. Try not to talk when you're taking your own blood pressure, and the arm should be resting at about chest height, really at the level of the heart. That's the idea behind taking your blood pressure, not too low and definitely not too high at the level of your chest. The cuff, avoid trying to have some type of cloth in between the blood pressure cuff and the skin. So just have the cuff directly on bare skin. Have your back supported and your feet flat on the floor in order to take an appropriate blood pressure reading. So what does it all mean? If you have high blood pressure, what does it mean? The next 3 to 4 slides really are a important discussion. It seems like there's a significant amount, but the approach is pretty simple. If you're an adult over 18 with high blood pressure greater than 140/90, let's presume here, then what do we do? How do we approach ourselves when we have that type of blood pressure? So the first thing to do is we implement lifestyle modifications, and we'll talk about that in the treatment portion near the end. What does lifestyle modification mean? Of course, we're talking about diet. We're talking about exercise, we're talking about weight loss. All those things become an important part when we're talking about lifestyle modifications. Then once that lifestyle modification is given some time to implement, what do I mean? Remember, I already said, you wait 3 months with uncontrolled hypertension, it's pretty significant, carries significant what I've already termed as morbidity and potential mortality in patients. So within a 3-month window of being diagnosed with high blood pressure and having instituted some type of lifestyle modifications, you should have your blood pressure and clinic visit within that time. And if at that time we can determine whether or not there's diabetes or chronic kidney disease, forget that portion, depending upon age, did we reach the goal that we intend to? You know, one of the things on this slide here talks about how age greater than 60, the goal can be higher than the general population if they're not greater than 60. That's also a big debate. This is from a publication that was done. This is back in like 5-6 years ago in JAMA, it's a Journal of the American Medical Society, and really kind of laid a new groundwork, and it's still a topic of debate. But the idea is you create a goal in mind, implement it, and based on whether or not they have diabetes or chronic kidney disease, we can determine a goal for blood pressure. Have they reached that goal? And if the answer is no, we have to institute some therapy in those patients, be it either a water pill, which is a thiazide diuretic, be it ACE or an ARB, which I mentioned at the beginning, because you have underlying diabetes or chronic kidney disease present in the patient, or do we need to institute 2 drugs at the same time? And we'll talk about that near the end of our presentation as well. So you institute a therapy. On follow-up then, has that therapy achieved the goal or improved or helped us in getting to the goal of blood pressure? And if the answer is no, we either add a second agent, we maximize the first agent, or go about a different type of a workup. But the important part at the end is we need to be able to achieve the goal blood pressure that we're treating. And once we attain that goal, we have to continue to monitor and make sure we're maintaining that goal throughout. So compliance is clearly going to be one of the issues that comes in, because lifestyle modification is one thing, where we have already talked about within lifestyle, we're talking about exercise, weight loss, eating properly, those habits become, or even sleeping properly are part of your lifestyle modifications. We have to be able to instill those. Despite that, if we're not able to do it, we have to have medications. And those medications, this is very important, my second part here, hypertension cannot usually be cured. And what do I mean by that? What I mean is hypertension requires lifelong therapy for patients. And that's an important part. It cannot be a question of, hey, doc, how long do I have to be on it? That's not it. The question is, can I achieve normal blood pressure with lifestyle modifications, and what type of medical therapy am I required? And it's a lifelong therapy. Just it's an important part to keep in mind. And of course, cost is an important part. Medications can be costly, but it's a discussion to be had with the physician. There are other options, but at times even those become constrained along the way. And then lastly, I've already mentioned that a 3-month wait between being diagnosed with high blood pressure and initiating therapy carries a significant risk to us as patients. We need to effectively go to those providers and be present and be involved in the care. So before I move on and discuss ambulatory blood pressure monitoring, because this is very important, I see some questions in the chat. So I'm going to ask the moderators to kind of help me and see what type of questions people have.
Dr. Mohideen, so far, no questions yet. We will give it a few more minutes.
Oh, okay.
You can continue with the presentation.
Okay. So again, if anybody has a question, you can chime in. You can still hear me, right?
Yes, Dr. Mohideen, we can hear you. Right.
So, so I've said, once you've diagnosed with high blood pressure, there's a certain therapy that gets involved, and certain level of monitoring is also required, which occurs via management through your primary care physician or nephrologist or cardiologist or other practitioners. Well, there's a key component in all of this, and that is your ambulatory or home blood pressure monitoring. Your blood pressure should not depend upon clinic to clinic visit. It's very important to know what your blood pressure is on a daily routine at home and at various times of the day. And what do I mean by various times of the day? Well, this study, which is already 10 years old now, it's an Italian multi-center study. It showed that if you take blood pressure throughout the day, at night, this is just one component of ambulatory blood pressure monitoring. At night, if you do not see a significant drop in blood pressure, such as if your daytime blood pressure is 135 over 80 or 130 over 80, and your nighttime reading doesn't go towards the 120 over 70, it's actually deleterious for your body, and it's deleterious for potentially progressing chronic kidney disease, heart disease, etc. This lack of nighttime dipping, or the actual reverse dipping where your blood pressure actually goes up at night, let's say because of poorly controlled sleep apnea, for instance, this actually increases the risk of renal renal disease or chronic kidney disease and other endpoints for patients. So this one study really shows the value of monitoring your blood pressure at home and knowing how it varies throughout the day. The goal always, though, the blood pressure should always be, in somebody who's a non-diabetic, less than 140 over 90 all the time. So let's talk about what does...
Dr. Mohiuddin, if I can interrupt you for a minute, there's in the chat box, somebody's asking you to repeat the apnea point.
Sure. So, there's a whole slide focused specifically on obstructive sleep apnea and how it relates to hypertension. So I'm going to just ask you to hold off on it because it's a discussion that we will do when we talk about secondary hypertension. It addresses exactly that point, is why does sleep apnea lead to poorly controlled hypertension? There are two different types of hypertension, and I've already kind of hinted towards it. First is your genetically mediated. Unfortunately, the most common, most prevalent form is the primary or essential hypertension. Then there is a significant portion, and it's growing in prevalence. It used to be 5-10% when I was coming up in training. Now it's up to potentially 20 to 25% of causes of high blood pressure tend to be secondary. And anytime there's a suggestion that there's secondary hypertension, we need to work that up in order to figure out, is there some therapy that we can do to help do a goal-directed therapy towards treating that form of high blood pressure. So what type of testing do? We look at the heart. We want to look at the heart rhythm. That EKG, the electrocardiogram, can give us a significant amount of information on your left ventricle size, your atrium. It tells us whether or not the heart has been affected or is a cause of your high blood pressure. A urinalysis, which is a urine test, it tells me whether there's blood, microscopic blood, not gross image, not blood that you can see, but only blood that shows up under the microscope, whether there's blood in there or protein in there, because those are key indicators for me that I should take more swifter action to help control that person's blood pressure. The fasting blood glucose. We've talked already about diabetes, how diabetes is a key component in managing high blood pressure, changes the goal, changes our therapy on it. Anemia, having anemia, we look at certain blood tests, potassium, sodium, calcium. Now these levels here are not meant to teach you any of it. What I mean to show by these tests are, we do this in order to help us further understand what is the cause of the high blood pressure. Can we treat in a specific way to help bring blood pressure under better control? And of course, we talk about diet. Is there some component of the diet that we can address? So I do see a question here. I'm able to go into the chat box. At what time of night does a patient need to record to look for a decrease of blood pressure? Oh, very yes, and this does. The second part is easy. Does this hold good even for somebody on treatment for hypertension? The answer is yes. That we don't want to see a reverse of the nocturnal dipping, but we certainly do want to see at least stabilization or a dipping of blood pressure at night. The first part, at what time of the night, is a very, very tough question. because technically when there is an ambulatory blood pressure cuff that gets sent home from the clinic, it's actually a 24-hour, every 15 minutes, and it can be different frequency, blood pressure monitoring. So technically we're talking about right in the middle of the night when you're already sleeping and this cuff goes off. I don't know about you, but having a blood pressure cuff go on and off and really squeezing that brachial artery is going to wake me up, and probably is going to affect my blood pressure. It's a tough one. But that is what the study was based off of. On the other hand, what I've done is I've come up with a different format of how blood pressures should be taken. And what I tell my patients is stagger your readings. So let's say you're going to take your blood pressure every day. I say on Monday, when you take your blood pressure, make sure you take it first thing in the morning. Whenever you wake up, rest for 5 minutes, take your blood pressure and write it down in a diary. Don't rely on the memory of the machine. Write it down in a diary. Then on Tuesday in the middle of the day, if you're working, it's going to be later on in the day. That's fine, around 4 or 5. But if you're not working, at 2 p.m., it's about a good time. Make sure you haven't eaten, obviously, any type of salty food, anything that will interfere with the blood pressure reading. So within 30 minutes of having not eaten, rest for 5 minutes. Very important, this resting part. Rest for 5 minutes, take your blood pressure, again, write it down. And then lastly, on Wednesday, let's say, or the third time when you take your blood pressure, do it when you're already lying down in bed, about to go to sleep. Take your blood pressure at that time. You've already kind of relaxed and created a situation where you're about to be going to sleep. Take your blood pressure. At least it won't give me a nocturnal dipping, fine, but I want to see a stability at night or a slightly lower blood pressure. And that is an important part. Because if I see that evening blood pressure when you're lying down being higher, it gets me a little bit more concerned. And I may then begin to stagger your medications at that time in order to really treat that nighttime blood pressure and make sure that it's stable, if not lower, than during the day. Very important data that was presented by that Italian study, confirmed prior presentations or prior research done on high blood pressure. Now, secondary forms of hypertension take multiple different conditions. I'll kind of go over some, and as I promised, there's a discussion on sleep apnea that I will have as well. So renal arterial disease, what does that imply? And who should be screened? Actually, first, who should be concerned about for secondary forms of high blood pressure is somebody who's already been initiated on therapy and maybe on their second line of medication or even a third medication that controls blood pressure, and yet we're not able to adequately control their blood pressure. Those are patients that we should consider that perhaps they have a form of blood pressure that needs a goal-directed therapy. It's a different form, a selective form of blood pressure. Or somebody with a sudden rise in blood pressure when it's been well controlled for a number of years, and then you see a sudden rise. The young patients, especially the non-obese patients with no family history, are concerning, especially the young females are concerning for a secondary form of high blood pressure. Very, very what's called malignant hypertension, when the blood pressure is more than 200 over 100, we should be concerned about it. And then anytime age of onset before puberty. I'm an adult medicine practitioner. Of course, I don't see too many of the prepubescent hypertension, but that is a concerning part of secondary hypertension. So renal vascular disease, what do I mean? Very simply, young women especially, they have a disease called fibromuscular dysplasia. It just means that the arteries supplying the kidneys are sclerosed a bit. They're wavy or sclerosed or stenosed. So sclerosed means that the wall is kind of broken down a little bit. Stenosed means they may have plaque buildup on it genetically. And so we need to be able to treat that, or not genetically, but congenital, meaning they were born with it. And so we need to be able to treat it. In these patients, especially the young female, being able to have a procedure done where you get a stent placed to fix that blockage or that sclerosis helps significantly in treating high blood pressure. It's a done deal for the young female, especially, or even the young patients in general when they present and have artery stenosis. As we get older and develop, let's say, plaque buildup later in life, it actually becomes a very significant debate in the medical literature as to whether or not to treat them medically with medications or having a procedure done. It's a case-by-case decision. And why is that important? Because it's been shown that despite having a therapy done where we put a stent in an adult patient, they will continue to require almost a similar amount of medications. So now you've put them at a risk for a procedure, for its complications with contrast, et cetera. And still at the end, the value is we haven't gained much because we're still treating them with the same, almost the same number of medications. So it's one of those discussions that you have with the physician that's taking care of you, with the nephrologist that's taking care of you, to determine whether or not it's valuable or useful in going about treating it. There's a couple of things that really go into making that decision. And the first and most important decision is the size of the kidneys changing? If you see that the renal size on imaging, it doesn't have to be annually or even every 2 years, but renal size, if the size is shrinking of that kidney, then you can say, you know what, I want to protect that renal parenchyma, as we call it, and it might be worthwhile to put a stent there to protect that kidney size. Just a small tidbit into what goes into decision-making about treating an adult with a potential what's called renal vascular hypertension, or having arterial disease or plaque that can build up on the renal artery. That's one form of secondary hypertension. It's going to slowly lead into my second part of my discussion that really talks about chronic kidney disease. And so this is one of the toughest topics that needs to be explained. It's hypertension, high blood pressure, that's stress. Having, one of the analogies I like to give my patients is, imagine that you're standing at a seashore on a rock wall. So you're standing on a seashore on a rock wall, and the waves of the sea are coming and hitting against this rock wall that you're standing on. Well, the simple question is, what do you suppose will happen to that rock wall over time as the waves of the sea come and hit against it? And the question is, and the answer is, it erodes it. The wall starts eroding and breaking apart. Well, the similar situation is you have a kidney, which is a soft tissue organ. It has significant amount of cushion built around it, okay? But now you have the waves of the sea, which is your high blood pressure, coming and hitting against it chronically. Well, if water pressure can break down a rock wall, high blood pressure in a similar fashion, you can imagine, can leave a scar behind in the kidneys. That, by the way, is a similar thing that can happen with with the retinal damage that can happen, eye issues, strokes that can happen, and heart disease. So similar picture. So it's really important that when we talk about high blood pressure, we also have to talk about chronic kidney disease and its effect. I don't have to go through the epidemiology. It's there for you guys to read, and we'll talk about the different stages of chronic kidney disease. But this is an important slide. High blood pressure, like I've just said, can lead to kidney disease. The unfortunate problem here is, which is already unfortunate, but the further unfortunate problem is that kidney disease leads to worsening of your high blood pressure. And how is that? Why is that happening? It's because of number 3, all of these situations here. Because what happens is the scarring that settles in the kidneys makes your kidneys unable to get rid of your sodium properly. So anytime you have chronic kidney disease, your ability to handle sodium really declines significantly. And so now you start retaining sodium. Retaining sodium causes water to follow. And now you get fluid buildup. That's where fluid in your legs come. Fluid in your lungs can happen. And so that's what's called volume overload. That's purely due to sodium retention. And it can also lead to poor blood pressure regulation. I didn't want to go through to saying it's sympathetic, parasympathetic, et cetera, but it messes around with your sympathetic system. So what the end result is when you have chronic kidney disease is there's less blood flow going to the kidneys because of this loss of regulation that occurs, which then the kidneys attempt to compensate by increasing sodium reabsorption. Again, I don't want to go into the gory details of this, but when the kidneys see less blood because they're losing its normal regulation that can happen because of this chronic kidney disease, you begin to retain sodium, and by retaining sodium, less sodium is excreted. Now you have fluid buildup because of the sodium retention that occurs. It's a continuous vicious cycle that can occur. And then, so it's important, as you can tell, that we prevent the first part to begin with, which is make sure that the high blood pressure does not lead to chronic kidney disease. Just a brief story about what chronic kidney disease implies. G1, think of G as stages here. It is glomerular filtration rate, but in this presentation, just think of G as implying the stage of chronic kidney disease. Up until about 5 to 10 years ago, it used to be 5 stages, but stage 3, which is the percentage, if we just describe the chronic kidney disease as a percentage of kidney function, stage 3 was where a large majority of the population was. But realize that if we split up that stage to 3A and 3B, it was an important distinction in how it affects your bone health, anemia, et cetera. So these are the 5 stages of chronic kidney disease. And as you can see, as you go through each of the stages, stage 5 is when we start considering dialysis on those patients, but a large majority of the population tends to be in stage 3 kidney disease. So there's a question: can taking potassium supplement help balance sodium reabsorption? It's a setup question, I think, because potassium is a great mediator. It's as a nephrologist, if people are in the medical field, they're probably a little surprised that I would even mention that potassium is important. But yes, as much as it pains us, as you develop chronic kidney disease, your ability to handle potassium goes down. That's a brief summary of that phenomenon. It's a whole presentation in itself. But if you don't have chronic kidney disease, then having a high potassium diet, or at least a normal potassium diet, is protective. And there are studies. I did an entire presentation on the value of potassium in someone's diet. And then at the end, I said, but if you have these conditions, we are forced to limit your potassium intake. So the answer is yes, potassium should not be restricted in someone's diet unless your healthcare provider specifically points out to you and is in fact protective and helps with the sodium handling in the nephron or the kidneys. Thank you for that question. This slide, very busy, but it's very, very brief in understanding. What it's saying is, can you guys see my mouse?
Yes, we can see.
Yes.
Okay. As the stage of kidney disease progresses and you have worsening renal disease, those people that have more protein loss and worsening kidney disease do worse than someone who may have normal kidney function or have mild kidney disease and very little protein loss. It's suggesting that there are multiple things that go into our decision making, and saying somebody with chronic kidney disease has a higher risk of progression versus someone else. And that's what helps delineate the type of therapy we use on the patients. So what are some of the predictors of so there's a follow-up question: are potassium salts overall better than salt containing or than salt that are sodium? So again, we're talking about salt substitutes. So salt substitutes are, yes, in a general population that maybe has high blood pressure and no kidney disease, or handling potassium normally, potassium salts are definitely better. They reduce the salt load. There's no question about that. Sodium chloride, which is the form of salt that we're talking about, is not safe. Well, potassium, on the other hand, potassium chloride is safer and in fact has shown to help along the way. So the answer is yes, but with the caveats that I've mentioned before, that as a nephrologist, I have to unfortunately advise most of my patients and kind of go over their diet. And one of the questions always is, what do you use instead of salt? If you're salt restricting, and they'll say salt substitute. And that's when we go and really kind of delve hard and realize the sauce substitute they're using is high in potassium, because potassium has a very tangy taste, and a little bit of a tangy taste really makes the flavor jump out. That's why it gets used. And so we tend to have to reduce that in their diet. But in general, though, a salt substitute is better, which is potassium in a large majority of the cases. So what are the predictors of progression of chronic kidney disease? Clearly, we're talking about high blood pressure. So having high blood pressure is one of those things. Poorly controlled blood sugars, high cholesterol, smoking, obesity in itself. I don't have a separate slide on obesity, but it's an important thing. And it's been studied on multiple levels. Being obese or having metabolic syndrome or having high BMI, basic metabolic profile, it's shown that independently, so if you do not have diabetes, if you don't have family history, that just obesity in itself can cause high blood pressure in patients, and then the sequelae that can follow from that. So very important. Having chronic kidney disease can lead to earlier heart disease, and then ongoing exposure to nephrotoxins is a problem, especially in chronic kidney disease. What do I mean by that? In one of the other slides, and it's probably coming up actually in my next slide here. It's right here in the last thing here. And what's called non-steroidal anti-inflammatory drugs are an important cause of progression of chronic kidney disease. Just last week, I had a patient, normal kidney function, just a year ago, started taking meloxicam, Mobic. Now we're talking about a non-steroidal anti-inflammatory, what's called COX-2, which are more protective for the stomach. But she was taking a significant amount of the meloxicam and came in with acute renal failure, high potassium levels in the blood, and potentially needing dialysis. But fortunately, she came just in the nick of time. We were able to give fluids and actually had to give steroids. That's a debatable topic in the medical literature. And we were able to preserve her kidneys, and she was able to recover. But Dr. Dhananjay and others will tell you, do people end up on dialysis when they improperly, unmanaged, meaning where the physician is not overseeing their anti-inflammatory intake or their non-steroidal anti-inflammatory intake, lead to kidney disease to the point of needing dialysis? The unfortunate answer is yes, way too frequently do we see that. So how do we prevent it? Remember, I talked about the angiotensins, the ACE inhibitors and the ARBs way in the beginning. That's a key component that helps a lot in reducing the stress on the kidneys. We have to avoid nephrotoxins, which is listed down here with the non-steroidal anti-inflammatory medications. Now, one key component to that is baby aspirin, and even adult dose aspirin, but a baby aspirin is safe. It gets classified under the NSAID, but it is not the form of COX inhibitors that we talk about. And that's an enzymatic word. So I won't delve too long into that. But just remember, baby aspirin, which is very needed for the heart and to prevention of heart disease, is not what I'm talking about when I talk about the non-steroidal anti-inflammatory medications. I'm talking about your ibuprofen. I'm talking about the Motrin, your Aleve, your naproxen. I mixed both the label names and the generic names in there just because there's so many. You just have to be on the lookout for it, like Advil, etc. A moderate protein diet is important. You don't have an aggressive protein diet or a restrictive protein diet. A moderate protein diet, usually about 1 gram per kilogram type of diet, tends to be reasonable in preventing kidney disease. In addition to that, a lot of literature points towards less protein and less animal protein being an important part of that. So if you switch your proteins to vegetable sources, more important. But even within the meat or animal sources of protein, having white meat versus red meat. So that's having more of a fish, chicken, or turkey type of a diet as opposed to lamb, beef, and a majority of the pork is important. So keeping more of a white meat diet if you're going to eat animal protein. Of course, low salt diet, blood sugars, and then I won't go over treating acidosis. That's an important part for a nephrologist to keep an eye on. There's a state called hyperaldosteronism where we normally have a response called fight or flight. When I see a tiger, I better get excited and jump or run the other way. That's our fight or flight response. That comes from our adrenal gland. It has both an upper cortex and a medulla. And this is from the cortex. When it's overly active, it's not that we're frightful all the time. That's not what I imply by this at all. But our hormone levels are too high. What's called the aldosterone level may be too elevated. And in order to treat it, we have to do goal-directed therapy for that. So if there's concern, like having, one of the last few slides are a case presentation, and you guys can go kind of delve into that and look at it. But having low blood potassium levels, high sodium levels in the blood, and high blood pressure kind of suggests this kind of a state, and there's goal-directed therapy for that. So I kind of mentioned it. Someone asked a question regarding sodium salt alternative. Can kidney disease patients be advised to take? And the answer is yes, as long as you look at the label. The label should, regarding the potassium, the label should go along with what your nephrologist or your primary care doctor or your cardiologist is saying, which is that if they want you to restrict potassium, it shouldn't have a whole lot of potassium in there. There are other things that can give taste in food rather than potassium. So like for instance, and I don't mean to name drop because I don't have any shares in it, but Mrs. Dash, for instance, used to be 5-6 years ago, potassium was its key ingredient. Now Mrs. Dash has switched where its salt alternative is not potassium. It uses some other ingredient, which I can't recall off the top of my head. But those are things to pay attention to. And regarding this going back to this, regarding this hyperaldo state, you do need a CT scan and imaging to figure out what the cause of this hyperaldosteronism is. And there are goal-directed therapies for this. Sleep apnea. One of the members was asking, or viewers was asking about sleep apnea. It is a leading treatable cause of hypertension. Some of the symptoms include headaches, fatigue, daytime somnolence or sleepiness, daytime sleepiness, confusion, depression, personality changes, and can lead to some cardiac arrhythmias as well. Why do I even bring up all of these things? Is because what I want to point out is even though we consider sleep apnea to be a breathing issue or a lung issue, it's leading to multiple organ issues, headaches, having confusion, even cardiac arrhythmia, as you can see. And so why can that not include chronic kidney disease? And the answer is it in fact does. And it can also lead to progression of high blood pressure. So evaluation is important. Getting a proper sleep study, getting a properly fitted mask is important because OSA means obstructive sleep apnea. These patients tend to retain potassium and they don't respond well to medications. We can put them on a slew of medications that their blood pressure stays high. It's because they're not being properly treated for their sleep apnea. And it does lead to a loss of that nocturnal dipping that I mentioned to you about earlier. Phaochromocytoma, remember I mentioned briefly that the adrenal gland has a cortex and a medulla. Well, the phaochromocytoma, which is a very specific problem, headaches, palpitations, sweating, I'm going to be very brief. It requires a significant amount of urine and blood testing, but it's a medullary issue and it needs to be specifically treated at times, may need very aggressive action. Cushing syndrome, again, I'm going to be very brief. Think about it as being on too many steroids for too long of a time. So you are either iatrogenic, which means that you were given steroids leading to Cushing's disease, or you have an underlying enzymatic defect that leads to your body thinking that it's got too many steroids on all the time and can lead to this Cushing syndrome. And again, therapy is directed towards that. Some other medications, remember, we talked about NSAIDs. And so another one is oral contraceptives. So not a whole lot, 5%, but it is a significant amount still. 5% of patients taking oral contraceptives, especially with estrogen, can develop hypertension. And those tend to be people, especially with known risk factors, such as family history, that smoke, race becomes an issue, obesity, renal disease, and diabetic patients. So important to keep in mind to discuss all their medications, because just like NSAIDs, which your ibuprofen, Advils, they're not considered medications a lot of times. Oral contraceptives are not considered medications by a lot of the patients. So it needs to be delved into to try to delineate, try to pick out what medications they are on that they may consider are over the counter or are a general part of their lifestyle that they take. This is kind of cool. When I did a research on this, and I really cut it down to one slide. Again, this was like 10 slides that I put into one. Excessive fructose intake, which is your sodas. High consumption of soda, especially in sugar sodas, have been shown in observational studies. Yes, observation means there wasn't randomized. People were aware of what they were drinking when they were doing the study. They were at greater risk for high blood pressure. And briefly, and this is the part where I really kind of slimmed it down. The reason it does is it causes an increase in sodium reabsorption in the gut. And if you have increased sodium reabsorption, if you have high blood pressure and chronic kidney disease, you've just added more to that vicious cycle. And by the way, similar things were discovered that if you have underlying obesity or other metabolic issues, that drinking these excessive fructose diet soda lead to progression, worse progression than you would otherwise. And by limiting the soda intake, I mean, you're not seeing a miraculous drop, but a significant beginning of drop in blood pressure just by removing their fructose intake from their diet. So other nephrotoxins. Now, there are two in here that I want to point out, and very important things that I want you to stop taking without first discussing with your doctors involved in the care. Proton pump inhibitors, what are they? Those are the acid blocking for your GERD or your acid reflux therapy, the new standard of therapy for it. There's growing data to suggest that it can lead to some hypertension or chronic kidney disease in patients, but that's not confirmed or confirmatory, meaning during the workup, if we feel that maybe it's perhaps the proton pump inhibitor that's causing it, it's a discussion to be had on whether to stop the therapy and move on to something else like a H2 blocker or something that's similar that can have good results. There's a question about whether my discussion on fructose products includes fruits, and the answer is absolutely not. It does not include fruits. Fruits are not included in the high fructose discussion that I had. Antibiotics, certain antibiotics can be problematic, and most of them tend to be the IV antibiotics that can lead to some issue at the level of the kidneys, but some antibiotics can lead to chemotherapy. There are chemotherapy drugs, that's a very specific thing, but it can lead to some issues. And then lastly, I've talked about metformin. This is important. Metformin is a wonderful, wonderful drug. Anybody who has type 2 diabetes should, and if they need it, should be on metformin. Its benefits are amazing beyond just control of blood sugar. Its anti-cancer, anti-tumorigenic effects are wonderful as well. But on certain circumstances, you need to be monitored, but when you have chronic kidney disease and high blood pressure and diabetes and are on metformin, you have to be monitored, both the primary care doctor and the nephrologist, to make sure things are going safely. Again, metformin is in itself a 2-hour presentation when it comes to why it becomes concerning. But if you're on metformin, stay on metformin, 1. And 2, just make sure that someone is watching and monitoring your therapy, because it can lead to some underlying kidney issues along the way for those patients. Treatments for high blood pressure, and do they work? I remember I promised I was going to talk to you guys about lifestyle modification on blood pressure and weight reduction. So here on the left, or my left here, you have modification plan, what we do. And on the right here is the systolic blood pressure, the top number, and what its effects are. As you can see, having a weight reduction does the best in terms of reducing the systolic blood pressure. Eating a diet rich in fruits, vegetables, and low-fat dairy products has a fairly good effect on the systolic blood pressure. Reducing salt intake, physical activity, reducing your alcohol consumption, all have a benefit effect. So the answer is yes. If you listen to the instructions of your doc and they explain to you about the type of lifestyle modifications, if you really take it to heart and put it into play, we expect to see these results: significant reduction in blood pressure. But if lifestyle modifications are not successful and your blood pressure remains poorly controlled over 140, over 90, either at home or in the office, then we do have to start pharmacologic therapy for this patient. 1 versus 2 drug becomes a really important topic. If it's 140 over 90 that we're talking about, 1 drug is usually the point of starting. But if it's blood pressure that's considered stage 2 or blood pressure that's greater than 160 over 100, we know, just if you look at this therapy here, it's really hard to come to that 20 millimeters per mercury drop in the systolic blood pressure. We know we're going to need 2 drugs in order to achieve that result. So it's recommended if your blood pressure is at 160 over 100 to start with after lifestyle modification, you're probably best to start off with 2 drug therapy. Because remember, any delay in getting to the goal is really affecting the long-term outcomes of multiple end organs or other organs along the way. So really, I'm going to stop here. There is a presentation I have of a patient I had, but I don't want to get too involved in that discussion. But if there's interest, I can go on to some of the treatment slides here. But really, I want to kind of stop here and kind of see if people have any questions for me at this point.
Dr. Moyunuddin, I don't see any questions at this point. If you want to continue a little bit with the treatment, you could do that.
Okay. So I'm going to skip through the part where I have a patient discussion there. So I'm going to go to this slide here, which drugs to use. Uncomplicated hypertension. What do I mean by that? You have a patient that has high blood pressure without diabetes or underlying chronic kidney disease, let's say. So just pure high blood pressure, who is not young and not concerned for secondary hypertension. The first line agent is a thiazide diuretic in those patients. Now, if they are of African American race, it is worthwhile to consider other therapy, but thiazide diuretics tend to be the first line agent for blood pressure. Then as we progress along, we can talk about the ACE inhibitors or the ARBs or calcium channel blockers along the way. The second part is also very important. If a single agent, so if I start a thiazide diuretic, is not effective, what do we do? Do we increase the dose of the first agent or do we add a second one? And this is a discussion again. It's not one way or the other. And a lot of times when a physician or your primary care physician or your nephrologist or cardiologist makes a decision, it's really based on them having had patient experience, one, with similar kind of situation as what you're presenting with. So they'll make a decision based on that. If they know your compliance history, if they know how much of a lifestyle modification you're able to make or your other comorbidities, they may say, rather than maximize on the first one, I need to add a second one because I need to get your blood pressure to a goal. And we already talked about this. When your blood pressure is greater than 160 over 100 to start with, after lifestyle modifications, we have to start with two different meds pretty quickly. So one of the questions is, for high blood pressure, do both systolic and diastolic need to be high? And the answer is no. I brought this up in the beginning. Systolic has been shown in all studies to be of high importance. So your diastolic may be in the 50s, 60s, or 70s, but if your diastolic, if your diastolic is 50, 60, 70s, but your systolic number is higher than 140, we have to treat it. We have to treat that systolic number. On the other hand, if it's reversed, where your diastolic number is high, we can take a slight deep breath and attack it in a different way. but it still does carry some risk, but not as much as the systolic, but still should be taken seriously. And there are different therapies that can be done for the diastolic. And then the follow-up is my systolic is typically over one. Yeah, exactly. The 135/40, if you're diabetic, it's really important to get that blood pressure below 130/80. So that 130 becomes a really kind of a key part of that question. It's still showing up in the question and answer, but I guess I hope I answered the question there. And then remember that we treat hypertension based on the different variables that come. Many side effects are dose dependent. So sometimes when we treat patients, we use moderate doses, but in combination therapy in order to be able to get the best effect possible in patients. So we may not want to maximize it because we know it's a synergistic effect between two medications work better. And so we aim for the moderate dose of both of them in order to initiate therapy. And to aid in adherence and compliance, again, I've already mentioned it, but I want to keep addressing it. Titrating therapy based on home blood pressure readings is much more important than just waiting for clinic to clinic readings. That's why bringing that diary with you is really important. Lifestyle modifications is a lifelong thing. There's a question asking if lifestyle modifications for 3 months only, and the answer is that's the problem. That is not, remember one of my first slides was that hypertension is not curable in the majority of the cases. And why did I say that? Is it needs to be the same therapy for life. So whatever routine of exercise is created, it needs to be followed through for life. Whatever form of diet has helped to bring the blood pressure down has to be carried through for life. And then they added to start therapy. The question is, does lifestyle modification always have to be done as first-line agent? And that's actually a really good question. And the reason I bring that, I don't mean actually, it's a very good question, because if your blood pressure is 160/100, the answer is no, you do not just initiate with lifestyle modifications. You have to initiate some type of medical therapy for them in a large majority of the cases. That's a really good question to keep in mind, is what is the blood pressure coming in, and will lifestyle modifications achieve the therapy? Because as I pointed out in this slide here, when you do lifestyle modifications, what can I potentially achieve? Maximum 20 millimeters per mercury improvement in that blood pressure. And if it's already over 160/100, my lifestyle modifications is not going to achieve that goal. So very important to keep in mind for the patients. So there's a question about when can sleep apnea become a concern in kids? Very good question. I'm not going to be able to answer that. I'm an adult nephrologist. I don't deal with children, so I don't want to give you a certain age or time period. But I can tell you it carries a significant risk, not just for high blood pressure, for overall. So unfortunately not going to be able to answer that question. But if I can find an answer, I can forward it along, and maybe they can send out a message along the way. So rather than going and cutting, speeding through the rest, because there's a lot that goes into it, I'm going to end my presentation there. I believe it was up till 8 o'clock, and see if there's any last questions that may be out there. And thank you for your time. I appreciate it.
So Dr. Moyinathan, thank you for your presentation. It was fabulous. You showed us how common high blood pressure is and how all of us really need to know our numbers and take care of it when we know that we have high blood pressure. It's important to do that. Audience, thank you for your participation. Thank you for those wonderful questions. We all learned from each other, and that was very, very helpful and good. Thank you. So, it is nice outside, and the country has opened up, our state has opened up, we can go outside. If we are vaccinated, we don't even need a mask. So this is all great information that COVID is taking, numbers have gotten better. And a large part of this is the vaccination. So for those of you who've gotten the vaccine, thank you for doing that. And for those of you who've not, go ahead and get the vaccine, because that is the best way to protect yourself and those around you. So like Dr. Moinuddin mentioned, good lifestyle, eating well, exercising, all of this is great for a lot of different conditions, including high blood pressure. So it's nice outside. So go outside, be active, and take care of yourself. So with that, good